Hello, Daniel. Joshua. What's happening?
Hi. Let me wipe my face.
Okay,
Sweater.
so I think I'm not. I can't see everyone. Okay. Good afternoon again. I just want to see how to, to quickly share Dr. Akinla's screen, his slide, so that we can just, please, can we confirm that we can see?
Okay.
Hello, can anybody hear me, please?
Yeah, hello.
Hello, hello.
We can hear you, Paula.
I can hear you.
Hello. Hello.
Hello, sir. I can hear you. I guess
Hello,
they're having an internet issue. Good afternoon,
Okay.
sir.
Good afternoon. Good,
Yes,
good
sir.
afternoon, Chine. Okay. I can hear you. Okay. I think we're off the other side. Yeah. Mhm.
Good afternoon, Doc.
Good afternoon, Chine. How are you?
I'm good.
Good, good. So,
Maiwa. Maiwa, are you still there?
Sure.
Kaido, can you share your slides? Check if it's possible for you to share your slides. Let's just
Oh.
test that and we share it.
Okay, I already
Okay,
sent one.
sorry. Okay, sorry. Chinaya, I don't know if Daniel can hear me. Actually, just called Sister Buki and she's having internet issues right now. So what she was trying to say the other time before she was locked out was for Daniel to upload Dr. Kiola's
Slides,
to
yeah.
share Dr. Kiola's slides. Daniel, can you
Okay.
hear me?
Well, even if I just want to find out if he can share, because he's a panelist, he should be able to share it if he can.
Okay.
Well, let me see.
That's it's faster. If he can share it, it's better. He'll be able to control it. It's more faster for him.
Yeah, Daniel, I've made you one of the co-hosts, so you should be able to do all of those things. You can
Okay.
share your screen now. So.
Okay.
Okay, good afternoon again. I think there was a network glitch here as well. Good afternoon. Okay, Doctor, I thought I saw Dr. Aderomu here just now. Good afternoon, Chinaya.
Good afternoon.
Great. Please, Daniel,
Good
confirm the slide now. Samayawa, please, have you been able to share it with Daniel?
Well, yes, I'd already told Daniel, and he's made a co-host now, so he should be able to share it.
Daniel Okodi, please confirm you're here. Okay. Dr. Aderomu, I think she got locked out again. Okay. All right, Chinaya, I think you can can we just finally wrap up, the agenda just with the flow, and I think we could start because we have some attendees already. Just generally see that we're fine, most especially with the very first slide. Daniel, please confirm you're here and you have the slide now. Perhaps you're speaking and you're muted, we can't hear you.
Hello, ma. Good afternoon, everybody.
Good afternoon.
I don't think I have any slides, and I'm trying to sort out our Facebook and our YouTube page. So I'm on and off here.
Okay, please, can you see the slide? Can we see the screen?
Yeah, I
Yes.
can see the screen.
Yes.
So I think this is fine. I hope my network will remain stable. I've had to move from one network to the other. So I think we can begin maybe in another.
To avoid all of that, maybe we need to make Doc a co-host too, so that he will be able to share his slides if there's any glitch in your network.
Not able to.
Can we make him a co-host too?
Phone as well, right? So I'm not sure it will project right, properly with his phone, if you get what I mean. So we're trying to use a laptop to project that. Yeah. Okay. So I think we can start in maybe a few minutes time. Maybe wait for, I think we can all see attendees. There are 8 of them. Dr. Aderomu is not here. Smayawa, please, can you confirm So we know she's also ready with her slide. We can do some checks there.
Okay. She's actually still struggling with her internet, so I guess that's the issue. She's trying to log in too.
Yeah, I'm about to even change my internet as well. Let's go. Okay, she's here now. Good afternoon, Dr. Aderomu. You're muted.
Muted, okay.
Not here yet. Okay.
Okay. Can you hear me?
Yes,
Can
I
you?
can.
Okay,
Yeah, yeah.
awesome. My apologies for showing up late. I'm having all sorts of technical everything that can go wrong today. Good afternoon, Dr. Akiola.
Good afternoon. How are you doing? Dr. Aderomu?
Fine, sir.
Well done. Yeah.
Good to finally see you. I
Yeah.
remember seeing your former office in Premier.
Yeah, really. Wow.
Yeah.
Thank you. How's it been?
It's been good. It's been good. Thank you very much.
Pleasure.
And then I put out the flyer on my WhatsApp, and then a colleague of mine said, "Oh, from Wesley to Lautech." I said, "This one is
Wow.
So all of us about the grown people were waving our
Yeah.
Yes.
Good afternoon, Victoria.
Good
Good to see you
afternoon.
guys. Thank you for having me. My
Thank you.
sincere apologies for
It's okay.
the delay.
Okay. Are you able to your slides? Are you good to do that yourself?
Yes, I am.
Okay.
I'll be able to do that. Once I click share screen, I'll be
Okay.
able to do that.
All right. Fantastic. All right. So I'll leave the floor. My name is Bukola Odulami, Program Manager with the Foundation. I'll leave the floor to our moderator, Chineye Rajafa, so we could just start the webinar. Thank you so much, doctors. Appreciate it.
Thank you very much.
Hi, everyone. Rookie, before you run off, you need to come and do an intro of what Pistis Foundation is about. I think that's still your job. So maybe you should just introduce what Pistis Foundation is to each and every one of us, especially those who are joining for the first time. And then we'll now go ahead to continue with the program for the day. Thanks, Vicky.
All right, so I believe we're started off. Welcome everyone to this webinar today. Thank you so much. The webinar, of course, infertility, new trends in infertility management. We're starting off, and this is a program that the Pistis Foundation have put together. Pistis Foundation, I'll just give a brief intro, is a social intervention vehicle where we were incorporated in the year 2018, and our main core focus areas are in the health, the shelter, and the education space. I am Bukola Odulami. I'm a program manager with the foundation, and one of the core objective for us is total well-being of every one of our target beneficiaries, of our target audience, target community. And for us, health, of course, as we all know, is wealth. And it's not just about the absence of disease or ailments. It's pretty much even the well-being, total well-being. And our unique approach really is both in the curative and the preventive, right? So one of the overarching objectives also for us is to ensure that as much as we are pushing out information, as much as we are trying to ensure that we have access to health for our beneficiaries to, as many as we can, we also want to ensure that they are well informed on various health matters, which is why we are here today. This is what we do every quarter. We hold this health webinar every quarter. We started in 2020. And of course, for today, it's being channeled towards women. Of course, it's the Women Month at the same time, just to ensure that we touch on salient issues, that are happening in our world today and that will be of much impact and benefit to every of our audience. So pretty much Pistis Foundation is here to be a model provider in these three areas: health, education, and shelter. Thank you very much for listening. I'll yield the floor now so we begin the webinar. Thank you.
Thank you very much, Sister Bukola, for that brief introduction of Pistis Foundation. So without much ado, I want us to say hello in the chat room. Please, let's just say hello in the chat room. Let's get to know each other in the chat room. I know it's going to be very intensive. It's going to be we try as much as possible to make it not so intensive, but at least easy to understand. It's supposed to be a presentation whereby we don't speak too much medical jargons. We try as much as possible to make it easy to understand. Break it down. Everybody understands what we're talking about. So let's just say hi in the chat room and let us know where you're dialing in from. Are you dialing in from Lagos, from Abuja, from Ghana? Okay, the volume is low. Okay. Is it my volume or okay? Can you all hear me clearly, please?
Yeah, I can hear you. I can hear you clearly.
Okay. So I'm looking out in the chat room. Let's just say hi. Hi, Eniola. Hi, Omolola. Hi, Tayo. Where are you dialing in from? Lagos? Okay, from Lagos. Hi, Ola. Thank you so much. Thank you so much, everyone. It's good to have you here. Thank you so much for dialing in. We look forward to having a very, very interesting conversation this afternoon. Thank you. So before we go ahead, let me just introduce myself. My name is Chinenye Rajafa. I'm a pharmacist by profession. I'm also a sales management consultant, so pharmacist. And then I organize summits like this yearly. So that's why they always call upon me to moderate these kind of things. Okay, but it's always a pleasure to come here to come on webinars like this and talk about health related issues, because I'm very passionate about health related issues like this, especially issues that concerns mothers and children. So it's always a privilege to come on board and talk about things like this. So before we just I'm seeing all the hellos. Thank you so much. Let me introduce the first speaker. So each of the speakers has about 25 minutes to speak. Then after you speak for 25 minutes each, then we'll have questions and answers. Is that fine, doctors?
Yeah, that's fine.
Okay. So I'll introduce
whether Daniel was able to can he be able to share the slide from his hand? Because I'm joining with my phone. That's why.
Yeah, okay. Can share it.
All right. Thank you.
Okay, so she'll share it as soon as I introduce you.
Okay.
Okay, so let me introduce the first speaker for today. Okay, his name is Dr. Temitope Akinola. He's a consultant gynecologist and an obstetrician, we call it ONG, with keen interest in fetal maternal medicine, infertility, and family planning. He's a fellow of the West African College of Surgeons, member of the Society of ONG of Nigeria, member of the Association of Fertility and Reproductive Health. He had his undergraduate training at Nigeria's premier university, the University of Ibadan, and his postgraduate training in ONG training at the University College Hospital Ibadan too. So he's an Ibadan. I don't want to say that. I'll show you. Okay. So during his undergraduate training, he was a winner of the National Merit category of the Chevron Scholarship. Dr. Akinola is internationally certified by USAID and Mary Stoops, I hope I pronounced that correctly, sorry, as a trainer in family planning. He was a former consultant to the Premier Specialist Hospital. I think that's where I met you, VI, Lagos, and Reddington, exactly, Reddington Multi-Specialist Hospital, Lekki, Lagos. He was the former head of ONG at the Al Rayan. Did I pronounce that correctly?
Al Rayan.
Okay, Al Rayan, okay, General Hospital. That's Riyadh, Saudi Arabia. He presently consults. That's why you presently consult, right?
No, I presently consult for Evercare Hospital.
Okay.
I presently consult for the Evercare Hospital now. Yeah.
Okay, I think that was cut short. Sorry about that. So let me introduce you all to Dr. Akinola as he takes the floor right now. You're welcome, Dr. Akinola. A round of applause for him in the chat room, please.
Thank you.
Buki, please, can you share the slides? Okay, Dr. Akinola, I hope you can see your slides.
Yes, I can. I have, it's fine. I have a backup here. Yeah. Okay. So it's just, I'll just say next slide, that's all.
Okay, good. You're welcome. So, Dr. Kela, we're waiting for you.
Okay, for me to start.
Yes, please.
Okay. Are we in the hint program now, or we're still just rehearsing?
No, we're in the program now.
All right. Okay.
Yeah, we started.
Okay. Good afternoon, everyone. It's a source of pleasure to be part of the great work Pistis Foundation is doing, especially this March month, which is International Women's Month. And we've actually chosen a topic that is very, very relevant to not just the women's health generally, but I would say the couple's health. This is because a lot of times we label infertility as just the problem of the woman, which is a very wrong impression. By definition, infertility refers to an inability of a couple to achieve conception after at least a year of regular, adequate, penetrative pedovaginal intercourse. So if you look at that, it's talking about the problem of a couple. So the impression we have in our world, or let me say, majorly in Africa, where we see it as a problem of the woman, I think it should be erased. It's a problem of a couple together, regardless of whose tests are wrong, or who is labeled as, oh, it's the female infertility, or whether you call it mixed infertility. It's still a problem of a couple, even if the man feels his own parameters are okay. Now, what should be the approach actually to infertility or to evaluation of infertile couple? Now, a lot of times you find out that this working with that 1 year definition of waiting for a year doesn't work in our world. This is because, number one, people are getting married at different ages because people have to pursue their career, people have to get themselves settled. So you find out that the idea of waiting for a year may not work for everybody. In fact, for a woman who's above 35 years, if you keep telling the woman that you want to wait until 8 months before start evaluation, that patient is not going to come back to you. So that 12 months is not sacrosanct. I think it depends mainly on the age of the woman. And so it's a little bit controversial when the couple should start investigation. Also, because there will be a lot of pressure from friends, from relations. Many people expect when couples get married that the woman should start vomiting or start complaining of symptoms of pregnancy 3 months into a marriage. And they, unknown to them, it might be their own decision. You may have instances whereby a couple have agreed by themselves privately that, no, the first 6 months, we want to get to know each other. We want to use maybe barrier method of contraception, or we want to use natural family planning. We don't want to get pregnant. And people who are friends or relations are wondering that why is the woman not getting pregnant? So these are the realities of practical issues happening. But whenever a couple has been trying to achieve intercourse, achieve pregnancy, despite they have been having regular intercourse, then there's a need to start investigations. And what is our approach? The approach is, number one, to actually know that we want to find out whether are things fine generally, because if there is no sexual intercourse, for example, long distance relationship, or there's something about them that they've not sorted out, which I'm going to explain on very soon. Sometimes you may have, I've seen instances whereby other people are concerned about a couple trying to achieve conception, and ideally there has been no penetration. Really, it looks so absurd and funny, but in this particular case, the woman had what we call vaginismus, which is like a psychological condition where there's contraction of the perineal muscles anytime he's trying to avoid intercourse. Not as if the woman had been abused sexually when she was young or something, but it's an involuntary thing. And the man has not been able to penetrate, the hymen was still intact. So left to other people, they're like, oh, they're not getting pregnant, whereas there have been no penetrative intercourse. So we want to be sure that things are fine as far as sexual intercourse is concerned, no disorder with ejaculation, no disorder with erection. Are things going on the right way? Are they having it regularly? Does the woman understand her cycle? Are they having intercourse at the right time? Is she having anovulatory cycles? Because women without anovulatory cycles, you can only get them pregnant by chance, because you assume they're going to calculate their so-called fertile period wrongly, and therefore you might find out that there are months in which they have done things wrongly. Now, I want to start also by saying that there's a need also for adequate history taking to find out what is really going on. Because sometimes from the history taking, a lot of clues are revealed. For example, is there a problem with the hormones? Is there a problem with the man? Has the man had a groin surgery recently? Is there any history of exposure, especially now in this environment where the figures with male infertility is increasing? What used to be the figures in the literature in the past was that male infertility was 30%, but now we're having figures as high as 40%. SFA parameters are dropping. That is the reality from values from embryology laboratories, from literature reviews, from a lot of peer review articles. You see that male infertility, especially in the environment, is increasing. People have tried to give a lot of explanation. Could it be due to exposure to heavy metals? Could it be due to stress? And other factors that people are trying to find out. So history taking, there's a lot of things we want to find out from the man and the woman. And it should not be a matter of, like I said, the woman just pushing the woman out to go to see the gynecologist while the man stays at home. No, it should be a joint problem, and they should have evaluation together. Okay, now physical examination also very important, because you want to examine the couple. From a physical examination, you may get clues. And sometimes from both your history taking and physical examination, you may not be able to get clues until you start investigations. Now, we need to be aware that it's a multidisciplinary team, okay, that will be involved in your evaluation. You have your gynecologist, you have a counselor, you have a sexual health physician, you have fertility nurse, you have an embryologist, you have a geneticist, you have a radiologist, you have an anesthetist, urologist, endocrinologist. And this is not exhaustive. There are other healthcare. Is a team approach actually in fertility evaluation. You have a counselor will help the woman. Even we're at the point where if the woman decides eventually to choose the option of assisted conception, a counselor is the one that will take you through the journey, okay, of those different decisions. Your fertility nurse will guide you of the time to come for the injections, depending on whether you're on the long or short protocol for the for ovarian stimulation. Okay. Anesthetist will also be relevant if you're coming for hair collection. That's for those who are going to have in vitro fertilization done. And embryology is embryology is very, very key, because much of what is going to happen in the laboratory work is the embryologist. The embryologist is the one that will let us know whether there was fertilization, will let us know about the progress of the embryo, the grading of the embryos, even before the day of embryo transfer. So you find out that it's a team approach, and a couple who has infertility should not be embarrassed being exposed to different people, because that's another thing people don't like. Oh, why am I seeing different people? It's a team approach. You have a fertility nurse, counselor, sexual health physician. I think what is paramount is for the patient to know that your details will be held in strict confidence, okay, as far as fertility is concerned. Now, I want to move also to the investigations. And the reason why I deliberately put seminal fluid analysis first is because of my own recent experience in clinical practice. Now, I honestly feel that people are actually underrating the contribution of male factor contribution to infertility. A lot of times people just say the woman should go and sort herself out. In fact, you've had instances in blended marriages where the man says, well, in my former marriage, or maybe she was a divorcee or something, oh, he's giving birth before, and the man finds it very embarrassing to come for a seminal fluid analysis. Now, it's important to know that the fact that the man has fathered the baby before does not mean the SFA parameters are still fine. Now, that does not question the paternity of those previous children, because some people find it very awkward or a little bit insultive, telling them that they should come and do a seminal fluid analysis when they just told you that they gave birth. The man said, I fathered the baby 3 years ago or 4 years ago. There are things that can happen that can make a man's sperm parameters to drop. Occupational exposure to radiation, extreme of temperature, as he had a surgery, groin surgery recently that affected sperm production. And sometimes you may not even be able to find out the exact predisposing factor, okay? So for the seminal fluid analysis, we are interested, the preferred method of collection is actually masturbation, okay, from investigation. Whether the man is dropping the sperm for the purpose of evaluation or he wants to drop it for the purpose of egg collection, we prefer masturbation. But not everybody could produce sperm through masturbation. So sometimes you may have to prepare a special room for them in the clinic where the man will be with the woman, and for them to try to achieve intercourse. At the point where the man wants to ejaculate, then he tries to give them a sperm pot, what you call a sperm pot, where the whole of the ejaculate is dropped inside. Now, the truth about the matter is that we know that some of the sperm would have actually been lost, during the process of excitement, what we call pre-ejaculatory secretions. They could actually contain part of the sperm. And that's why we feel masturbation is actually more reliable. But if a patient cannot produce with masturbation, you must still try to do ejaculation. And there are also instances whereby you need to really, there are some people that even when you prepare a place for them, they will not, even when the wife is there, they will not produce any sperm because they find it, the anxiety is there. They cannot just produce in the hospital environment. So we need to be flexible and explain to the patient what you obtain. Some will have to do it in their house. Now, the proximity to where they're actually bringing it now becomes a factor because there's a liquefaction time for sperm, where sperm contains a lot of proteins and can dissolve. And also under the temperature under which it's transported, because you have instances whereby some patients will say, oh, no, I can't produce in an hospital. Whether I give me a room, I'll feel anxious. I have to do this at home. But where do you live? How close is the house to the hospital also matters. I must also explain that if a man has also had, for example, those who have had prostate surgery, okay, you can have what we call retrograde ejaculation. That is, part of the sperm you're trying to analyze is actually in their urine sample. So some people may have to have their sperm collected by what we call surgical sperm retrieval, surgical sperm aspiration. So, and that is why every other thing about them must actually be explained at the point of collection. So we are interested in the movement of the sperm, what we call motility. We're interested in the morphology. That is the normal forms, because the sperm must have an head piece, a tail, and a middle piece. So there's a way they must appear. And there's a value for each one of them and the sperm concentration. I must say that of all these parameters, the single most important one is the motility, okay? The fact that the man has a sperm count less than 20 million does not still mean he cannot impregnate a woman spontaneously. And when we're now talking about in an assisted conception, you can have a parameter in which you have low motility, low sperm concentration, but with certain methods in assisted conception, which Dr. Aderomu is going to share more light on our own slide, what we call ICSI, IVF ICSI, intracytospermic sperm injection. Some can still have their babies with sperm parameters that are actually below what is the optimal for spontaneous conception. So people should not give up entirely. And when you have the stations, the worst case scenario where you have azoospermia, no single sperm cell, we need to actually find out, is it obstructive or non-obstructive azoospermia to actually find out the solution. And some people may also benefit from donor semen. These are alternatives which Dr. Aderemu is going to present in our own slide. So the sperm parameter is very, very important. And also the other thing, the next thing is how patent or how open are the fallopian tubes of the woman. Very, very important. I'm going to start the next. Can we move to the next slide, please? Next slide. Next slide, please. Next slide. I'm going to the picture on the HSG. Next slide. The next slide, please. The one after this. Yeah, this is fine. So now this is like a picture, what we call an HSG. Now, women don't like to hear about this procedure, and that's because a lot of people do not give adequate pain relief during this procedure. So occasionally you see men say, oh, that painful test, ideally is not meant to be painful if given the adequate amount of anesthesia. And if you have a low threshold for pain, I think you should discuss with your gynecologist before doing the HSG that you want anesthesia, you want pain control before having this procedure done. This test is actually a radiological test where we outline how the fallopian tubes are they open? It also gives us more information about the lining, the inner lining of the womb. So if there are blockages, what we call adhesions, or the what we call the cervical canal is blocked, we get a lot of information, and this will guide us actually to know whether we should not waste our time in trying conventional methods of fertility treatment, and you may now have to move to what we call advanced management of fertility. For example, a patient with bilateral tuber blockage, and you're giving the patient ovulation induction. Ideally, before you start ovulation induction, you are meant to ensure that the tubes are open and the spermatozoa from the male partner is also fine, and you are sure that you are treating infertility that's due to a problem with releasing the eggs before you actually commence ovulation induction. If not, it's more like an exercise in futility, doing ovulation induction for someone with bilateral tuber blockage. Now, even when the HSG says the tubes are blocked, it is not always 100%, and therefore we prefer to do a diagnostic laparoscopy, which is, many of us have heard about laparoscopy before, is a minimal invasive procedure. Next, can we move to the next slide, please? No, next one. Yeah, that laparoscopy, that's just the picture of what the laparoscopy involves. You're trying to make a minimal access surgery. Usually we make an incision below the umbilicals to visualize the contents of the peritoneal cavity. So we want to actually be sure, are the tubes actually patent? Is everything fine and all that? And now in this picture, you may see that there are two other ports, and that's actually because it's not just a diagnostic that is being done here, an operative laparoscopy is being done. So maybe an ovarian cyst is actually also being removed. So that actually, the access to the other ports are what you're actually trying to see. So we need to do a laparoscopy. Now, also, you may have to do, so important, I've mentioned two important things now, the tubes of the woman being open and the male partner sperm being fine before you actually conclude. Now, the other factor I'm going to talk about is the ovulation, is woman ovulating well, okay? Now, one key thing, I was mentioning about the effect of maternal age for the woman. The biological clock of a woman ticks so fast, okay, such that the peak period for the fertility of a woman is 21 to 25. And the effect of maternal age is not just about the quantity of the eggs, it's also about the quality of the eggs. So above the age of 35, not only do the reserve, when we talk about the ovarian reserve, we're not just talking about the quantity of the eggs, even the quality of the eggs, okay? And that is why even when the eggs are there in good quantity, the risk of chromosomal disorders are actually higher above the age of 35, 36. Now, this is not to scare us, because honestly, if you look at our contemporary world, things about career and all that will make some people, not everybody will be lucky enough to marry very, very early. So people will marry late for different reasons, previous failed relationships, or blended marriage, or they lost their loved ones, or they married early and they lost their partner. So the advanced maternal age should not be a no-no to fertility. Some people will achieve spontaneous conception, and if there's a delay, actually, there are several options. Options of donor eggs. There's also the option of elective egg freezing, which Dr. Derum is going to shed more light about, where the woman can actually freeze her eggs at a younger age, while she faces career, while she faces other things. Because you cannot force a woman to marry the wrong person, not just because the biological clock of her age is ticking, okay? Because there are other problems that can be worse than infertility. So women can actually electively freeze their eggs and keep even till when they are ready, so that they don't I'm running out of time, just marry the wrong person. Can we move to the next slide, please? Now, a very germane issue, which my own area will not be concluded, is the issue of fertility and fibroids. It is a common issue that keeps cropping up. We get to see a lot of people who, for the first time, get to know they have fibroids, maybe because they are now married, they're trying to get pregnant, and therefore they did a scan and they saw fibroids. And you can see the picture I'm trying to show, the uterus, and showing different locations where it could be. Let me at this junction state that the fact that a couple has been waiting to achieve conception and they have fibroids does not always mean the fibroid is the reason why they're not getting pregnant. Now, it is true that different literature quotes different percentages of cases where the fibroid may be the reason why the woman is not getting pregnant. But as a gynecologist, we always want to exclude other reasons. Because if a woman does a mammectomy, that's a fibroid for a surgery for fibroid removal, with the aim of, oh, I have infertility and I have a fibroid, so it necessarily means the fibroid, and you go and remove it without finding the cause, you may do the mammectomy and you may not get pregnant. Now, don't get me wrong. Some people may do the mammectomy and they get pregnant, because there are ways in which fibroids can actually cause infertility. If you have a fibroid in the inner lining of the womb, that affects where the pregnancy should settle down for. Okay, that may be the reason why the woman is not getting pregnant. In fact, it may even be the reason why she's not having a successful IVF. She has good embryos, but the embryos are not settling down in the inner lining of the womb, what we call the endometrium. So sometimes they may say, okay, go and do this fibroid surgery, okay, and that might improve the chance. Sometimes fibroids at the junction of the fallopian tube and the uterus can also affect the transport of the fertilized egg, okay? So the point I want to say, Jermaine, is it is not a rule of thumb that infertility and fibroids means the fibroids is the cause. No, there are other things you want to find out. Is the husband's sperm okay? Is she ovulating well? Are things fine? Before you conclude that the fibroid is the reason why the woman is not getting pregnant. And when a woman has infertility and fibroid, you need to actually do enough consultation, if possible, seek a second opinion before you decide on the suitable method of management, okay? Because there are certain methods that we may not really recommend alternatives to surgery for people who are trying to achieve conception. So for people who are trying to achieve conception, there are different ways we consider, because we are considering the inner lining of the womb. You don't want a situation whereby you've done a lot of work to stimulate a woman, you had good quality of eggs at egg retrieval, you have good embryos waiting, and just because there's a problem, there's an endometrial factor or factor within the lining of the womb, the woman is not getting pregnant. Okay, so this is very, very important in that. So there are different locations where it can be. The fact that you have a fibroid does not mean you cannot get pregnant. And it's not dependent on size. A woman can have a fibroid very big and she'll get pregnant with it and she delivers with it. Someone else may have a fibroid very small, but because of the location, that is why she's not getting pregnant. So the issue of fibroids and infertility is not mutually exclusive. It must be fully understood so that you don't have instances of a patient who has done 2 previous unnecessary myomectomies being done, okay, especially in the young. In the young, we are always very careful before we are convinced that this woman needs to have the fibroid removal because of the potential for scarring of the inner lining of the womb, which is very, very important. Next slide, please. So I can also, I can't end my own part without mentioning polycystic ovarian syndrome. Many of us have about PCOS. PCOS is the commonest hormonal condition in women. Now, some women may get to know when they were teenagers or when they were in university, they menstruate maybe once in 3 months or less frequently compared to their friends. So they go for evaluation and find out they have PCOS. Not all people with PCOS will have problem with infertility, but PCOS is a known cause of anovulatory infertility. That is a reason why the woman is not ovulating well. Okay, and the way we manage is, the way we manage PCOS in a woman who doesn't want to get pregnant is different from somebody who wants to get pregnant. But someone who wants to get pregnant, you may start with ovulation induction. There are different things we can use. Some will succeed with ovulation induction. You have the obese and the non-obese type of PCOS. So that may actually influence the kind of medication. Some require Clomid, which is very popular. Some will require metformin. Some people will require letrozole. Some people will not achieve pregnancy with all that because you have cases of PCOS that are called clomiphene citrate resistant PCOS. And some people, you may have to now move to injections, okay, HMGs. And the truth about the matter is that whether we like it or not, some women may still have to do IVF, even for PCOS, okay? Some people may have to do IVF if the parameters are very, very bad. Now, there are other anovulatory disorders. Not all problems with ovulation means is PCOS. In fact, a lot of times people may overdiagnose PCOS, okay? You just look at certain factors and you conclude it's PCOS. There are so many other hormonal conditions that are endocrine in nature, but they are not necessarily PCOS, but they can affect ovulation of the woman. And therefore, the hormonal profile of the woman is very, very important. Your FSH, your LH, you are analyzing your B21 progesterone guides us as regards the kind of treatment that the patient should do. Now, I'm also going to talk about on the medical interventions. The next slide, please. The next slide, please. Yeah, medical interventions. Like I said, we must know what we are treating. I have seen many people, well, they come in taking Clomid. Why? Somebody said they should take Clomid. Why? Has it been established? Even sperm parameter of the partner has not been checked. The fallopian tubes have not been checked of the woman. So you're giving the woman Clomid. That's what would that achieve? Or you're using Clomid and your partner is not even around. So what? Because you're using any medication for ovulation induction, you are working towards intercourse that same month. So you must be guided. There must be like a follicular tracking to find out, oh, is there any ovarian response? And to guide, that's what patient who is trying to achieve through a natural cycle, okay? You guide the woman as regards when the intercourse should be and certain interventions to be done. Now, some people also have, from their hormonal profile, have elevated prolactin levels, okay? Elevated prolactin levels, which may or may not manifest with secretion of milk in the secretion of milk in a non-pregnant from the breast. Okay, there are different medications. Why we try to ascertain the cause of the elevated prolactin, okay, which sometimes may even require doing some imaging, okay, to find out there's no tumor or swelling or what we call pituitary tumor, okay, is that you need to actually do something about the elevated prolactin in some cases, because that may even be the reason, is a known cause of ovulatory disorder, okay? So while you're trying to work on ovulation induction, the prolactin levels need to be connected. Now, some may require the human menopausal gonadotropins, the injections. Now, these injections are for the purpose of ovarian stimulation. And very often what we do is what we call controlled ovarian stimulation, which Dr. Aderounmu is going to expand more on that light. Now, on a final note, before I allow the second speaker, my colleague, Dr. Aderounmu, to talk on what to do when natural methods are not working or conventional methods are not working, I think we need to understand that a lot of support is needed for the infertile couple, okay? The support from the organization, the support from the family, the support from the friends, because it is not an easy task going through all these investigations. And I usually say, women go through a lot. The only investigation a man may have to do is just to produce sperm, which you do that through sexual interaction, through a pleasurable mean, a pleasurable act. But the woman is the one that will go through HSG, go through laparoscopy, go through hysteroscopy. So you find out that it's, whether we like it or not, it's meant to be a couple's problem, but you see the woman still bearing much of the burden, okay, especially in this environment. And that picture needs to change. That picture needs to change by giving support, by us not labeling infertility as a woman's problem. Even if the man has done an SFA and found our parameters, but there is need for support, actually, to find out. And I must explain that there are cases of what we call unexplained infertility. Unexplained infertility, the man's sperm is fine, the woman's fallopian tubes are open, the woman is ovulating well, and they're still not getting pregnant. Okay, unexplained infertility happens, and assisted conception is actually a known modality for managing this particular condition. Thank you. Thank you very much.
Thank you so much, Dr. Akela. This was a really insightful presentation. In fact, I've been trying to get started, and I know that a lot of people will have questions to ask. So what do we do? Do we take the questions after the 2 sessions? Or
yeah,
take a few now, then what?
After, I think after will be better.
Take note of your, yes, please. Take note of your questions. After the second session, then we'll be able to ask all the questions together, and then we'll have the question and answer session at the end. But before we go ahead, I just want to drop this question and let Dr. Kela respond to this as we get ready for the second speaker. Dr. Moji, are you getting ready? We're getting ready for you.
Okay.
So talking about freezing of eggs in Nigeria, how realistic is that? With our epileptic power supply, and I don't know how to answer, but in my mind, I'm just thinking, what has been your experience with freezing of eggs in Nigeria? Is this something you would recommend, or you think we need to go to another country to freeze our eggs if we have to?
Well, I'm sure. Well, let me just say my own little bit. I know Dr. Aderounmu will say more about that, because now there are a lot of advances going on. It's a reality, whether we like it or not. I think it's an option we need to let people know. It's available. The facilities are available. Okay, and Dr. Aderounmu is going to. She works in an assisted reproductive technology center, and I'm sure she's going to let us know about this. The facilities are available. I think people need information to know where to get these things available. The expertise is available locally, the facilities, but I think what you're talking about is the power thing. Well, the power thing is a reality, is affecting a lot of things. You can imagine, even with diesel price going up now, you can imagine what IVF centers are going to be going through, because you have embryos stored, you have things that must be kept, you can't just do that without power. So it's a reality that there's a challenge, but the facilities are available, okay? And women need to know that it's an option, because, okay, let me use Lagos as an example now. People are married late, not because of their choice, but it's just the reality. Before you settle down, before you start a career, by the time you start a career, you are not even yet financially ready on the woman's side. So whether we like it or not, people marrying late, it's a reality. People want to face career, want to face other issues. And therefore, by the time they are ready, the biological clock is not waiting. You have fibroids all over ready, you have the egg reserve is reduced. So the option of elective egg freezing, it's something people can pursue so that you don't just rush because of the biological clock is against me and you married the wrong person. And now you want to treat him, you want to avoid infertility, but now you are now facing domestic violence. You understand, which is another problem. So yeah.
Okay, thank you so much. Second question dropped in before we go ahead. Someone is asking, is it possible? What's this myth about being of childbearing age and not taking in or getting pregnant, even though you're not married, but having that's one of the things that puts pressure on young ladies. Being of childbearing age and not getting pregnant when you're supposed to can be a high. That can be one of the risks of having fibroids. How true is that? Is it a myth or how true?
No,
how true is that?
No, delaying childbirth. Nobody knows the exact cause of fibroids. Okay, what is known in literature is that delaying childbirth is still a risk factor for fibroids. Delaying childbirth is a risk factor for fibroids. Black race is a risk factor for fibroids. Genetics, okay, is a risk factor for fibroids. But the exact cause is still not known. Just like many conditions in gynecology, where the exact cause is not known. Nobody knows the exact cause of endometriosis. Nobody knows the exact cause of preeclampsia. So for fibroids too, nobody knows the exact cause. But delaying childbirth is a risk factor for fibroids.
Okay, thank you so much, Dr. Kiola, for clarifying that. Thank you so much. So let's move on to the next speaker, Dr. Mojisola Aderomu. She's MBBS and FWACS. Don't worry, that's part of me. I think she's a fellow, and then also let me know boy that, but it's part of her. I think one is a fellow, right? One is FWA, fellow West African Council of Surgeons, right? And the medical practitioner.
Yes.
Great. She graduated from the University of Lagos in 2008, where she obtained her MBBS degree. She went on to serve as a medical officer at the General Hospital Mubi, Adamawa State. Her passion for women's health has further cemented during this 1 year and led her to a postgraduate residency training in ONG at the Lagos University Teaching Hospital, Idiaraba, Lagos. She's a consultant ONG with a passion for maternal medicine, ultrasonography, and the management of infertility. She passionately supports causes for the well-being of women and girls. She spends her free time engaged in advocacy and volunteer work for a couple of non-governmental organizations, such as the Girls Say, the Habidel Foundation, Beyond the Classroom, and now Pistis Foundation. Let me add that to you. She's the executive director of the Amira Peitola Foundation, a not-for-profit organization that awards academic scholarship to deserving secondary school students. She has publications in reputable local and international journals and has attended several international conferences, including a poster presentation of the 2016 RCOG conference. I think that's reading conference, right? In Birmingham, United Kingdom. She's also a member of the Nigerian Medical Association and Society of ONG. She has held several leadership positions over the years and presently is the medical director of Medical ART Center Ikeja. Let me introduce to you Dr. Mojisola Aderomu. Please, a round of applause for her as she comes to talk to us about alternative means to parenthood, right? I'm not sure I got the topic right, but I think there's some alternative means, new trends in alternative ways to being parents. Thank you so much, Dr. Mojisola. You're welcome. A round of applause for her, please.
Thank you very much.
Yeah.
I'd like to share my slides. Okay. Thank you very much to Pistis Foundation, the Elevation Church, I see the good work you are doing in the community. You recently collaborated with Palon for surgeries for some of the patients who had fibroids, and I was able to pitch in with some of my colleagues. So you are doing an awesome work, and God bless you all. God really, really bless you. Yes, it's a honor to be speaking today with my fantastic colleague who has done a lot of, in fact, I had to be writing notes like I'm medical school again. Thank you very much, Dr. Akinola.
Thank you.
Thank you so much for doing a powerful groundwork. Thank you so much. And I will appreciate one of my colleagues who extended the invitation, Dr. Etowoma. I'm very grateful. Miss Mayowa, I'm grateful.
Okay.
Yes. So today, I'll be speaking about infertility management, the alternative ways to parenthood. And I'll try to be as brief as I can. Is my screen being shared? Yeah, I think so.
Yes, it is.
Okay, so this is the outline I will be following. Dr. Akinola has already mentioned quite a number of the things that you would need to understand. And we'll just quickly run through the ones that he has said, and then we'll come down on what I'm going to be adding to it. He has already made my work easy by doing most of the definitions of infertility. And so, and he has broken it down to those who have had children before, you know, that's when it's secondary, and those who have never had children before, that's primary. The definition has also expanded recently to cover those who have been pregnant but have not had a live birth. So you may be seeing your doctor and the person gives you a definition, and that's not what they said at that Pistis Foundation. So don't worry, you are still covered under all the possible definitions as it may be used. Now, for fertilization, we need the egg, we need the sperm, and we need a home, which is the womb. So the man gives the sperm, the woman gives the egg, and then when the egg and the sperm have merged and have formed an embryo, which is a potential human being, all of us started as embryos. The embryo needs a very safe place to land, to be nurtured, and that is the womb. The baby bed is the endometrium. You see that lining of the womb that Dr. Akinola had talked about is very, very, in fact, as gynecologists, we guard it with our hearts when we are doing myomectomies, because we know it can be the determinant in whether a woman is going to have complications later on or not. So we really take a lot of our time. So when people say, oh, the woman went in for myomectomy, it took 6 hours, just know that at least 4 of those hours, or maybe 3 of them, was spent on making sure the endometrium was very well repaired. So the sperm must meet the egg when it is released from the ovary. That's ovulation. So every woman, every adult woman, you know, will actually have grown one egg and release it in one menstrual cycle. If she had sex at the time when that egg was released, she will get pregnant. If she had sex every other time apart from when that egg was released, she won't get pregnant because they were not meeting at the time that it was necessary for pregnancy to occur. And if you look at my picture, you see that after the fertilization has occurred, it travels back and attaches into the womb and implants on that endometrium. So we have fertilization, which occurs when the egg is released at the time sperm is deposited. Within 5 to 15 days, when the implantation occurs in the womb, and then usually about that time, which is the woman misses her period. So when a woman says she missed her period, it means that it was supposed to come, but she hasn't seen it. It's not that it has not reached the time it should come and then she's looking for it. It doesn't work like that. So if she's expecting her period to come, let's say on the 12th of April, and the period doesn't come on the 12th of April, then she has missed it. She can't miss it if she's checking on the 10th of April. So that's basically how it works, because the cycle has a specific length and it's different for different women. So you find that during the evaluation, and especially for the hormone profile, the doctor asks woman A to do her progesterone on day 19 and ask woman B to do her progesterone on day 21, it's because he's working with her own menstrual cycle. So that's why, like Dr. Akela said, you can't adapt your friend's treatment regimen to yourself. You can't even offer your own treatment regimen to your friend because both of you may not necessarily have the same pattern, the same cycling and all of that. Now, for the causes of infertility, Dr. Akela has done a fantastic job on that. The male factors, the female factors that have to do with the tubes, that have to do with ovulation, he has really covered a lot of ground on that. Now we are going to be, so this is basically it. Reasons why a couple may not be pregnant: not ovulating, male factor, age, he has mentioned the age, blocked tubes. He made a very cogent statement when he said, before you swallow Clomid, you should have checked for the tubes. And I've seen not a few women who actually had, they say, we have used that Clomid, it didn't work. And then we do an HSG and the tubes are blocked. And we're like, madam, it couldn't have worked because there was nowhere the sperm was going to pass. Then endometriosis, which is an enigmatic disease on its own, and it keeps not a few gynecologists awake looking for how to find the cause and how to address it and how to make women's lives better. Now, I'll be talking basically on the treatment options available. Let's start with the simple ones and then we'll move on to the complex ones. So we've laid the groundwork on the fact that the sperm needs to meet the egg at the time it is released from the ovary, at which point fertilization can occur, and then it has to travel back into the womb where it implants. And then when implantation has been successful, in about another 2 weeks, then the woman misses her period because the period won't come as long as pregnancy has occurred. Timed intercourse. Every time I raise this with my clients in gynecology clinic, I usually joke with them and say that when it comes to timed intercourse, we have to blame Lagos traffic, especially when your couple are really trying and then one of them is still on Third Mainland Bridge at 7 a.m. and that one is still in Woodlawn at 9 p.m. and it's difficult for them to merge their schedules in such a way that they actually can make this work. So timed intercourse has to do with the fact that, especially if a couple have a hectic schedule, or we know that the woman is ovulating, we've done tests, we've evaluated her and we know she's ovulating, we've evaluated the man and know that his sperm parameters are great, but they don't have a lot of time because when we say regular, unprotected penile-vaginal intercourse, we're looking at 3 to 4 times a week. That's an average of 12 to 16 times in a month. That's roughly half of the month. And so many couples find that hard to keep up with. They're like, before we get home, before we cook, before we this, before we that. So timed intercourse means that we calculate based on that woman's cycle length, the possible time when she ovulates. So we'll know by evaluation that, okay, a woman who has a 28-day cycle will likely ovulate on day 14. So if we're looking at doing timed intercourse, we say, okay, Mr. and Mrs. A, because you are likely to ovulate on day 14, by day 12 to day 16, we want you to have sex. Have sex day 12, day 14, day 16, or day 12, 13, 14, 15, 16, depending on how they can cope. So that's what timed intercourse means, that we are timing it to the fertile period, the period where the egg is likely to be ovulated. Now, Dr. Akela also mentioned ovulation induction, and that's where Clomid comes in. Most people are very conversant with the Clomid. In fact, I don't think you need a prescription in this country to get Clomid. Or some people even give their leftover Clomid to their friends or their colleagues or whatever. So that's the commonest one. But there are other medications we use. Ovulation induction means they are using a medication to induce the ovary to grow and release an egg. Now, Clomid is one, letrozole is another, and there are other ones that we use depending on what the woman's peculiar medical history is. And like you rightly said, for some women, we need to add injections to it. Those are hormonal injections we give that mimic the hormones that the body usually releases in order for eggs to grow and be released. So some women will do well on just the tablet. Some women will need the tablet and injections. And then they still need to either do timed intercourse. So for example, I have clients who husband works in Edo State, wife works in Lagos. So they can time their free weekends, to be during their wife's fertile period. And then they come home, spend time together, have sex, and then they can go back. That can work. Now, for some people that cannot do timed intercourse, there's an additional procedure we'll go on to do, which is the intrauterine insemination. Now, with both timed intercourse and insemination, the man's sperm parameters have to be good. Because what we are trying to do is to just mimic natural conception by aiding the sperm to reach the egg in good time. So for example, I have clients who are, husband is offshore and onshore, maybe monthly or every 2 months, and the woman is ready, her evaluation is fine and all of that. We can then do intrauterine insemination for that. So most times they would have given us a semen sample that will freeze, and then they can go offshore. And then with time, monitor the woman, give ovulation induction. And then when ovulation is set, we've achieved good sizes, then she comes in and we do an insemination. Sometimes too, it may just be that there's no, there are theoretical reasons. Some things are like cervical mucus is not so great, so natural conception is not working. By doing an insemination, we bypass that because we are the one introducing the sperm directly into the uterus. And then it can spill out through the tubes that we've previously evaluated on HSG and assessed to be open. And then the woman can achieve pregnancy with that. So after going through timed intercourse, intrauterine insemination, there are still some couples that may not be the answer to their quest for fertility. And then we go on to IVF, in vitro fertilization. What IVF means basically is that egg and sperm that meet inside the woman is done in the lab. And then when we have that embryo, that potential human being that all of us started from, when we have it, when there's fertilization in the lab, we have an embryo, and then we put it back into the woman's womb, just as if we were doing insemination, or we're putting an embryo back. That's just what IVF is. So it's more invasive, it's more costly because there's a lot of laboratory work that goes into that, medications as well. So most people hear IVF and they're like, no, but it's been the answer to a lot of families to have their own children, complete their families, and to be satisfied knowing that they asked some questions and they received answers. The world's first IVF baby is 44, and she already has her own daughter. Or I'm not sure if it's a daughter or a son, but she has her own child. And every time I think about it, I look at it like she was the breakthrough. God shed light on that idea, and the scientists were able to keep refining until they got it. And what was the reason? Her mother had lost the tube to ectopic, and they didn't even do a stimulation cycle for her. They just allowed her to have a natural ovulation and then, collect the egg and then did the IVF in the lab and then put it inside her womb. But since then, there has been so much advancement in the field of IVF that IVF is answering so many questions that otherwise would have been left in the dark about. Now, because we collect the egg from the woman, usually, the woman that being on medications, she'll be on regular scans to ensure that eggs are the follicles, which is what we see on scan. The eggs are microscopic and are inside those follicles. So as the follicles grow, it's believed that the eggs themselves are growing and maturing. So the woman is on medications, the follicles are growing. We've reached the size where we should give injections, ready to collect those eggs. Then the woman goes to theater under light sedation, and then we retrieve the eggs. There's no cut on the abdomen, so it's done through the vagina. We retrieve those eggs, and then we hand it over to the lab, and the lab uses a fresh sample of sperm from her husband, or even a frozen sample of sperm from her husband, to fertilize that egg and get an embryo. For women who don't have husband, who are not yet married, and they want to, have their eggs frozen, the IVF will stop at retrieving their eggs and freezing it, because we are not going to be fertilizing with any sperm. So we can freeze that until they are ready to, have, maybe they along the way they've gotten married, then their husband brings a semen sample. We then thaw those eggs and fertilize. So it's like a pause in their own treatment. And these days, they're, like Dr. Akela rightly said, you can't ask a woman to marry because of the biologic clock, and then end up solving other problems like domestic violence. Even the children raised in those kind of homes, it will take a lot of support and God's intervention to raise healthy, normal children. So for women like that, they can freeze their eggs. It's usually best if you freeze before 35, because 35 seems to be like the golden age for a lot of things in obstetrics and gynae, and risk of certain things get higher after 35. Of course, it's not so common to see less than 35-year-olds coming to freeze their eggs in Nigeria. But these days, I'm beginning to see more women between 35 and 40 who are single and want to freeze their eggs, because they want the opportunity to be able to have genetic children of theirs whenever they are ready. So as long as the eggs are frozen, they are there for as many years as you can. I think there used to be this movie I watched when I was much younger, by Sandra Bullock and Sylvester Stallone, where you just freeze a human being and then you thaw the human being, and then that's something like that. That's how it is. So the process is you take the egg and you freeze it, and it stays that way until you thaw it later on, and then you can fertilize with semen sample to make an embryo, which is a human being. So women who are not yet ready can have their eggs frozen. These days, more and more women between 35 and 40 are beginning to look into that option. And to answer the question that was asked earlier, yes, definitely the facilities are available in Nigeria. For most of the established IVF clinics, including the one where I work in, we have cryopreservation facilities. We do the IVF, yes. So we freeze eggs, we freeze embryos, semen, so you don't have to travel to the US or UK. If you ask around in Lagos, you will. And more smaller facilities, smaller IVF facilities who don't yet have that capacity are beginning to liaise. So even if facility A, which is pretty young, doesn't have the infrastructure to do that, they actually may be liaising with facility C somewhere else that has an established infrastructure, and they can make arrangements for you to have those your gametes or your embryos frozen. So you don't really have to go outside the country to do that anymore. You don't. And not just the egg is being frozen, the sperm as well. And that has been a source of, well, let me say peace of mind, some peace of mind. When it first started in the Western world, you have people like soldiers or astronauts that are going off for commissions, and the wife is not sure whether they're going to come back. So the men can, freeze their semen sample and go off, knowing that it's an opportunity for their spouse to be able to have genetic children of theirs with them. Of course, legal frameworks have evolved to be able to match that, because medicine cannot outstrip technological and legal advancement. We must always work hand in hand so that the society doesn't break down. Now, IVF with own gametes, that's the most common one. A man and a woman who together have tried to have children of theirs and they haven't been able to. Depending on the evaluation, we know whether the man has sperm, whether the woman has eggs of enough quality and quantity. And then we can use that, put back into the woman, and she gets pregnant. That's the commonest one. The other ones are donor gametes. And in the few years I've practiced in the space of IVF, I think more or less culturally, a lot of us still struggle with donor gametes, but it's becoming something that is pragmatic nowadays. So if the woman is much advanced in age and her evaluation shows that she doesn't have good quantity of eggs that we will get if we're going to stimulate her, not to talk of quality that declines as the age of the woman goes up, then we offer donor egg. So, and we explain to them, because when she says, will this child be my child? What I usually tell them is, you raise the child. You infuse your values into that child. The child is a reflection of your values. It's not necessarily your genetic material. And somehow it helps them to be able to have closure on that. As much as possible, we match. So we match a woman who is going to be using donor eggs, physical characteristics, blood group, and all the other medical things that shouldn't raise a flag, so that we can't have a very dark skinned couple and have a fair complexion child. Everybody's going to say, that's where is this child from? So when we match as close as possible, they don't have to give any explanation to anybody, unless there's a reason for a DNA. And of course, they can always request that their treatment summary be sent to the requesting authority to show that this is the type of IVF they had, and this is why there's chromosomal disparity between one parent and that child. Now, I've found in practice, funny enough, that when a couple comes and we have to use donor egg, there's less resistance. But when we have to use donor sperm, we have to do a lot of work. You have to do a lot of work because it takes men a longer time to accept that they are going to be using a donor sperm for that treatment. And in reality, just like Dr. Akinola said, I've been seeing younger and younger men having oligo, terato, all sorts of abnormal parameters with their SFA. It may be that we are westernizing so much that diet and all of these other things we are adapting is affecting the semen. But there really is no way to say why so many younger and younger men less than 40 are having really, really bad sperm parameters. So sometimes we have to give them time for treatment, give them supplements to help, and then once we're able to get some measure of normality, then we time their IVF for that period, so we can have a good sample that we're going to be using to do the fertilization, because the quality of that embryo is dependent on the quality of the egg as well as the quality of the sperm. So that takes us to donor eggs and donor sperms. The last one I'll be talking about is surrogacy. So for some women, now we've gotten the egg, the sperm, or the embryo themselves. For some women, they are unable to carry the pregnancy. Either they have problems with the uterus, whether they've had previous procedures and uterus is damaged, or they even have medical problems that preclude them being able to successfully carry a pregnancy without losing their lives. So for those women, surrogacy is the answer. Also, if a woman is coming in much more advanced in age, in Nigeria at present, we have the EFRH, which is our regulatory body. Once a woman is more than 54, we shouldn't be putting any embryo into that woman. So we should be doing a surrogacy treatment for that couple, because at 54 and above, it's not safe it's not healthy for that 54-year-old woman to be carrying an IVF pregnancy. So we'll be offering a surrogate treatment for that. Now, when it comes to surrogacy, I think I will use the next slide to explain that. Yes, you have the intended parent, and then you have the surrogate, which is the gestational carrier. And then later on, you see the parents now have this baby that was inside the gestational carrier. I'm going to now explain the different types of surrogacy treatments that we have. So with the surrogacy, this is a copyrighted image from one of the texts. So I acknowledge that at the end. With the type of treatment for surrogacy, you have the couple here. They have their own gametes, their own sperm, their own egg. But because of some medical reason or some health reason, the woman can't carry that pregnancy. So we put it into another woman who helps us to carry that pregnancy for that couple. We can also have the woman has her own egg, but we are using donor sperm to get that embryo. And then we put it into a surrogate. So that means this woman is not healthy enough to carry her own pregnancy. We can also have donor egg and the husband's sperm. That means this woman either is too advanced in age or she has other medical reasons why she cannot give us good quality eggs that we can fertilize to get an embryo. So we have a donor egg, husband sperm, and a surrogate to carry that pregnancy. We can also have donor egg, donor sperm. For some couples like that, both partners have issues with their own gametes. So donor egg, donor sperm, and then put into a surrogate. And when the surrogate has a baby, then the baby goes through the intended parents. We call them the commissioning couple. So these are the different types of surrogate arrangements that may arise in the course of IVF treatment. Of course, all these treatment modalities is different across different countries and guided by policy and law, depending on the country in which you are practicing. For a woman to be a surrogate for another couple, she must have children of her own. There are some criteria the surrogates themselves must meet. She must have her own children. She must be medically fit. She must be psychologically fit. She must also understand the legal implications of what she's doing, because it's a contract. And even though we don't have a specific surrogacy law in the Nigerian polity, it's based, the surrogacy agreements are based on the respect for contractual agreement protected by law. So the woman having understood and her legal representative having been involved with it, and the couple having understood and their legal representative being involved, they agree that this embryo is being housed by this woman. When she delivers, then we go home with our baby. And everyone is expected to honor that agreement. The last part of it, which is not a treatment in itself, which is why I didn't add it, there is adoption. Some couples, this may be the answer for them, because they may have had several failed cycles of IVF and they are not willing to go through the emotional and financial roller coaster again. Adoption is an answer. And like I put up these pictures, you see these children saying, after 1,031 days in foster care, today we were adopted. The last picture says, I shared their love and their family, and today I share their name. There's a lot of joy that comes in being able to open up our hearts and our homes to children who are in need of it. And I've heard, astonishing stories of couples who took that leap of faith and decided to go for adoption, went through the process, adopted their baby, and boom, they are pregnant naturally. They did not do IVF again. So yes, there are mysterious things that happen, and we cannot take away the hand of God when it comes to being a blessing to other people. adoption may be the answer for some people. And with that, I would like to end my long talk. Thank you so much for your attention, and I'm open to any questions. Thank you very much.
Thank you so much, Dr. Mojisola. Thank you. God bless you so much. In fact, I wish we had more people here, because I know that this is it's becoming a thing of very, very frequent thing in our community. You know, I recently was waiting for, I was at the hospital when there was when you're talking about the myomectomy, taking about 6 hours. I was in the hospital a few days ago and I witnessed it. So, and that was part of the question that was on my mind. So I can imagine a lot of women are going into surgery without even understanding the implication of what they are doing, or even understanding the basics of what is happening to them. You know, some women just go to the doctor and they just want to tell you what to do based on all the information they have heard from their colleagues and friends and families and everything. So this session is really important. And I'm so happy that both of you were able to simplify the topic and make it easy to understand. We're getting lots of questions. I'm sure some of them might sound ridiculous to you, but it's just the kind of questions you see in the community, in people, in homes. Questions people ask their family, friends, and their friends, and the kind of answers they get. So it's good that this is happening, and we'll definitely share the recording for people to hear and watch it to get the right information. So let me share some of the questions that are in the chat, in the question and answer box, and then we'll go from there. So someone is asking, good afternoon, doctor. We had our first child already, but we have been planning to have a second child, no conception yet. Transvaginal ultrasound scan has been carried out. Conclusion, normal study. And then she says, we've been trying for this for about 9 months now. What is the solution, and which other tests would you recommend? Thank you. That's it. That's the first question.
Can you take that question again? Can you take that question again, please?
Let me take it again. Good afternoon, doctor. We had our first child already, but we have been planning to have a second child, but there's no conception yet. Then she says she has done a transvaginal ultrasound scan.
Yeah.
And it has been carried out, and the conclusion is it was a normal, there was no abnormality, normal study. And she says that they've been trying for about 9 months now. So she's asking, what is the solution, and which other test do you recommend that she goes to take?
Yeah, so what she has is secondary infertility, because she's had a pregnancy before, she's delivered, now she's trying to do. Now, transvaginal scan being normal alone does not mean every other thing is perfect. Like I said, you know, it may look somehow absurd. The partner still has to have a seminal fluid analysis, you know, and like the usual issue is getting that man convinced. A lot of times I prefer to do the talking with the man, at least as a man. Like, you need to, let them know that we are not trying to say you are not responsible for your first child, or you're trying to say this, but sperm parameters can drop. There are so many things that can make sperm parameters to drop. So we need to evaluate the man for seminal fluid analysis. Even we need to also do our hormonal profile, okay? Then we need to also assess the tubes again, because following that delivery, whether it was a normal delivery or cesarean section, things could have gone wrong. Was she an infection after that delivery? Okay. Sometimes there may be no pointers. The tubes may be perfect, okay? And it might just be some other things that have cropped up. Hormonal condition, you may need to find out, you know, what is really going on. And in some cases, you check the hormones, everything is fine. You may still be unexplained infertility, which you now have to think about assisted conception. So transvaginal scan alone being normal does not mean everything is perfect. It's still a need for her to have a detailed evaluation. She may need to have an hysteroscopy done if indicated to assess the inner lining of the womb. The male partner has to have evaluation done. And we need to actually, so that will determine what needs to be done. And she didn't mention her age, because her age is also important. How old was she when she had the other baby? So her age now will let us know how to, especially when you're trying to interpret the hormonal profile results, and you're trying to look at her AMH and all that to assess her ovarian reserve, so that you want to make a decision on time, okay? Based on what I said about the effect of maternal age on the quantity and quality of eggs. All right.
Okay, thank you so much. We'll wait for her to comment on about her age. But we have a question, another question. I think Dr. Mojisola, this is for you. I think I will list out the two questions at once, because I'm sure.
Okay.
The first question is, please, when eggs are frozen, can the woman still be seeing her periods normally? That's the first question. And then secondly, the B of that is, can an abortion alter a woman's menstrual cycle and cause infertility?
Okay, so the answer to the first question is yes. The
you get
woman
the
can
question?
see her periods. Yes, I did. Can you hear me?
Yes, we can hear you.
Okay, so yes, a woman can see her periods normally after the IVF, the retrieval of the eggs, and the freezing. It doesn't affect her menstrual cycle. Because what we've done basically is that rather than the woman grow and ovulate one egg in the cycle and then have a menstrual bleed because she's not pregnant, we've given medications to ensure that more than one grows. We've collected those eggs, but because she's not pregnant, she's still going to bleed. So it's not going to affect her menstrual cycle at all. So she can have IVF, freeze her eggs, and have a menstrual cycle and continue to have a menstrual cycle regularly. There's no problem with that. Now, with an abortion, it depends on what was done. Abortion can be done medically or surgically. So if she had used medications for that, yes, there may be changes in what is her regular menstrual pattern. And it shouldn't exceed 1 or 2 cycles before it goes back to normal. So, and when it says, will she have infertility? No, unless she has complications, she's not going to have infertility. So, for example, if the abortion was done in a safe manner and she had infections, the infections may damage the tube or damage the lining of the womb. Yes, as a result of that, somewhere along the line, it can account for infertility, maybe due to tubal damage or due to damage of the endometrial lining. So one of the common things I used to see when I was in training residency was that a young woman goes for an abortion and has curettage. Now these days we don't do curettage again. We do suction evacuation. So now she does curettage and they've scraped that endometrium, that precious endometrium that we need to be able to, have implantation. Scraping has gone on and it's been damaged. So it heals with scarring. It can heal with plastering, we call it adhesions. That in itself can now be the cause of infertility down the line. If it was done in an unsafe manner and the woman ended up having infection, that can spill over into tubal damage, and then she can have blocked tubes and she can need, assisted conception because of infertility due to tubal damage. So if an abortion is done safely, it doesn't have complications that lead to infertility. I believe I've answered that question.
Thank you so much.
You're welcome.
Yes, you have. Thank you so much. Okay. So someone is asking, Akela, this should be for you. What causes tube blockage?
Oh, okay. Tubal blockage can arise due to several reasons. Okay. It could be due to congenital reasons, that is, things that just happened without any cause, right from the way she was born. It could be due to infection. A common cause is an infection, pelvic inflammatory disease, and that can happen as a complication of maybe she's had a previous gynecological procedure, like maybe evacuations in the past that were not properly done, or she had an ascending infection, okay, from a poorly treated vaginal infection. You can also have it due to things like tubal endometriosis. Tubal endometriosis. Endometriosis is a condition whereby what should be the inner lining of the womb is present elsewhere. So tubal endometriosis can cause tubal blockage. Infection can cause it. There are so many other tropical infections that can cause tubal blockage, especially procedures that have been done in the past in the woman, gynecological procedures in the past resulting in that. But a leading cause is actually pelvic inflammatory disease, okay? Or things like, also like you mentioned about criminal abortion, especially if it's not well done by trained hands, well-trained hands, if she's had an evacuation in the past and it was not properly done, or whether by the skill of the person or the safety of the environment and all that, things like that can cause tuber blockage.
Okay, thank you so much, Dr. Akela. I hope your questions were answered. So if you have any further questions, you can drop them in the question and answer chat box. So the first question we asked that was earlier, the lady has responded. She said she had a CNS for her first child and she was 34 when she had that child. So probably she's still about 34 now because this is about 9 months after she's been trying, or maybe she's 35. So she just responded. So she's about 34, 35 now.
Oh,
in case
9
you
months.
Want to go, in case you want to answer the question for that, Dr. Akela.
9 months. Oh, she 9 months after delivery. Really? I was actually thinking it was the prolonged because 9 months, you need to find out, is she still breastfeeding? Because you don't expect
maybe she should clarify.
Yeah.
Clarify. She should clarify. She just said she's been trying for 9 months now. I don't. Yes, that's true. She needs to clarify.
Even with
Have you been trying for 9 months? Meaning 9 months.
Because even with that cesarean section, she shouldn't get pregnant immediately. A birth interval of at least a year to 18 months is what is recommended for someone who has had a cesarean section. Okay, you don't want a patient who has had cesarean section to just get pregnant.
The birth interval should even extend to 18 to 24 months.
You know, so I'm wondering why. So in that case, there might be nothing wrong.
I think maybe she should clarify. Maybe she just started trying 9 months ago. I think she should clarify. Please clarify your question. Before then, let us go to other questions.
In addition to that, sorry, ma. In addition to that, because she's had a procedure done on that uterus, it would be good for her to do an to have an HSG done. I don't know if she did that. Did she?
Okay, she has clarified. She has, she's 37 now. She's been trying for 9 months.
Okay, I think she should still do an HSG, even though the scan is not done. Yeah.
Yeah, so that's highly recommended for you. Please do an HSG test. Get it done. So the next question is, I've been diagnosed with PCOS. Should I get it treated now, or can I wait till I'm ready to have kids? Does it get worse over time without treatment?
Okay. Well, let me just my own input. PCOS, number one, it's important to know our age.
Do you want to help us?
Yeah, polycystic ovarian syndrome is an hormonal condition. Okay. Now, it's important to know what our age is and what symptoms she's having, because the way you manage PCOS, like I said, depends on whether she wants to get pregnant or not. Okay. So if a lady is diagnosed with PCOS and she's young, she's still single, what I'm interested in doing is to actually counsel her on weight reduction, then also maybe stabilize her cycles. Okay, maybe what she was stabilization of cycle, because you can't be doing ovulation induction for somebody who's not thinking about getting pregnant. But even if she's still single, because we know that not all patients with PCOS will have problems with future conception, but we know that there can be a challenge with ovulation. So while she was diagnosed very early, there are a lot of things she can do. Optimization of our body mass index in terms of the weight control, diet, lifestyle modification, checking out for blood sugar and other things are also very, very important, because these are things people miss out in this environment. Preconception, you won't say because you're not yet thinking about pregnancy, but you want to put yourself in an optimal state of health even before when you're ready to get pregnant, so she can have preconception. However, if she's already in marriage and PCOS is already diagnosed, then there should be active management of that infertility, which can be stepwise. Some, like I said, we start with conventional agents of ovulation inductions. Some you have to do controlled ovarian stimulation. You have to combine with injections. Some may eventually have to have IVF, and some may even have to have donor eggs done for them IVF with donor egg, depending on how bad the picture is. Okay, so it depends on our peculiarity of our condition. PCOS is an indication, can be an indication for IVF, but not all patients with PCOS will have IVF. Some will get pregnant on their own, some needs to be assisted to have ovulation induction done, and some ultimately may have to have a form of assisted conception done.
Thank you so much, Dr. Akela. I think you answered the question effectively. If you have any further questions, please just put them in the chat room. I'm looking at the chat, the question and answer chat box. So, Dr. Moji, this question is for you. Will fertility treatment or birth control pills make me add weight?
That's a very common question. But then the way I explain it is this. The basic arithmetic of adding weight is that you are expending less calories than you are taking in. Yes, there's the part that hormones have to play in it. So in order to keep one's weight down, you watch what you take in, the total amount of calories. You can't take in 4,500 calories every day, expend 1,000 calories and expect not to gain weight. Now, if you're able to first of all control the diet and then add, short exercises to it, you can take a walk 30 minutes. I know the country is unsafe these days. You can actually walk around your sitting room for that 30 minutes. Just keep pacing until 30 minutes is up. You can do aerobics. A combination of diet and exercise can actually really help to control the weight gain. That's me. It's not common with all types of contraception, actually. It's commoner complaints with those who take injections and all of that. But when they apply that diet and exercise, they're able to actually get traction on the weight gain.
Thank you so much, Dr. Misola. I think we've been able to answer that question. Let me go on to the next question. My husband and I have been trying to conceive for years. Test shows that there's nothing wrong with both of us. What could be the issue? Is there such a thing as sperm and egg incompatibility? Dr. Kela, do you want to take that?
Yeah, well,
my husband and I have been trying to conceive for years. Okay.
Unexplained.
Get the question.
Unexplained infertility exists. Okay. And by unexplained infertility means that we have been able to do the common tests of infertility. You've checked the husband's sperm, you've checked the woman's tubes, you've checked the woman is ovulating well, and you still cannot find a reason why she's not ovulating. Now, a lot of people mistake unexplained infertility does not mean there's no cause. Because there are other causes, or let me say rare causes of infertility that you do not have clinical tools to determine. For example, how do you determine how many in the laboratory, or how do you determine issues of immunoincompatibility, okay, at the immune level, which actually in research, there's enough evidence in science and research that there can be, those things have been theoretized, hostility of the cervical mucus and things like that. So theoretically, those things are possible, they've been explained, but you don't find any commonly available commercial kits or investigation tool to determine that, I'm talking about commonly available to determine how two people to find out their, what we call the HLA, human leukocyte antigen, or things like that. They're not commercially available, in terms of you're trying to test it, but it's the patient, this person should know that it's possible to have unexplained infertility. Unexplained infertility can even be an indication for you to also have IVF done. And it does not mean that there is no cause. It only means we have not been able to find out the cause, because there are, in medicine, sometimes you have what we call idiopathic causes. Within the limits of the investigations you can do in your own environment. Let me give you an example. If you do an hysteroscopy on a patient to look at the inner lining of the womb, and a fine hysteroscopy alone does not 100% clear the patient of problems of the inner lining of the womb, because You are talking about the things you can see with your naked eye on gross examination. There are still things that happen at the tissue level. Sure, you understand? You understand what I'm trying to say? So that and this happens to some people. There are people like that who they've had their investigations done. They go for, after waiting for 3-4 years, they go for IVF. And I've had personal patients like that. Some, the IVF, I've had a patient, the IVF worked, and after, she felt there was only for her to be on birth control because she felt she was infertile. And lo and behold, she got pregnant spontaneously while she was waiting. So how do you explain that? Okay, so you see things that happen occasionally like this, that sometimes you know that it's medicine is not 100%, or when it comes, you don't, it still advances things. When it comes to knowledge, things are still happening that people are still trying to find out, oh, what could be the explanation? You know, just like people have done, BTL has been done before, and the person comes and the pregnancy happened, and BTL is meant to be a permanent method of contraception. So it's to let you know that the same thing goes for fertility. You are trying to stop it, it's coming. Now you want it, is not staying. So things like this happen.
Indeed, sir. I know. I've heard of a lot of stories like that.
Yeah.
So let's just, we have so many more questions trickling in. Let me just see if we can handle all of them before our time is up. So Dr. Mojisola, if you don't mind, take this next question. It says, I've been trying to conceive for almost a year now. I've done my HSG, hormonal profile, and my husband has also done his semen analysis, and everything is fine. But my gynae has advised we go for intrauterine, I think that's supposed to be an examination, right? Next,
IUI.
but for my findings, it's IUI. Next, but for my findings, it seems the degree of success is just about 15% per try, and it may need to be done multiple times. Please, would you advise I do the IUI? I'm going to be 34 in October. Or do I try using Clomid first? I would ask this question along with another question, which is similar. It says, what is the success rate measured by live births for each type of treatment? So that would just be something you just answer together, please.
Okay, so if your gynae has recommended IUI, let me start from there. There must have been a lot that went into evaluating you to say IUI would be a better idea than doing natural intercourse and waiting to get pregnant. Now with IUI, the advantage you have is that you'll be having folliculometry. So that means you'll have a scan monitoring to see if you're actually growing those eggs that can attain the size of the follicle that should ovulate before your husband's sperm is introduced into your uterus. You are correct about it being multiple times. Now, natural cycle. If you take 100 fertile couples and they have sex, all of them are fertile, no problems with any test or whatever. Only about 20% of them will actually get pregnant. The first time that, okay, this January, 100 fertile couple, nothing is wrong with them, have sex, only 20%. And that's natural. It doesn't mean there's anything wrong with the 80% that didn't get pregnant. What IUI does is adds an extra 2% on it to make it 22%. IVF, as fantastic as it sounds, raises it to 25, 27%. When we now disaggregate into age group of the woman, is she younger, is she older, and all of that, we can then be saying, oh, the success rate is 50%, is 67%, and all of that. But those are figures. But when we break it down to what the clients can understand, they see that it's not a magic bullet. Like Dr. Akiola said, unexplained fertility exists, and there are people who truly have several cycles of IVF. They've had good quality embryos, and endometrial thickness is fantastic, and all of that. They didn't get pregnant. So there's still that part of it that for now, in another 10 years, something may come up to explain why that happens. But for now, we don't know why that happens. So when you have to do an IUI cycle more than once, quite a number of my clients get pregnant their second IUI cycle. So, when they have the first one and then they didn't get pregnant, they cry. And I tell them, okay, it's good to cry, but we have one more shot. Let's do this. And then I had a client who she had actually done IVF twice, and she was 39. So when she came to see me, we spoke. She was emotionally really down, and I looked at her evaluation and said, we could try, IUI. I made some adjustment to her treatment protocol and all of that. The first cycle failed, and then she came and said, "You see, I told you, even the IVF did not work. It's now this IUI you want to try." And I said, "Even it's okay for you to be disappointed, but I'm not giving up." So I spoke to her, encouraged her. She came back for the second cycle, and that one worked. And then the first trimester was really rough. And she will come and say, "I'm tired." I say, "You can't be tired, though. We prayed this child down." So you cannot be tired. So IUI can work, but you may need more than one cycle. Don't be discouraged if the first cycle didn't work. I have clients who get pregnant the first time. In fact, I had a client who said, "I don't know why they say this IVF doesn't work. The 2 times I've done it, bam, bam, it just worked like that." I didn't have the words to tell her because I was like, thank God you don't know. Because there are people who do know the pain of that. So it's different for different couples. But don't give up because the statistics says. Yes, the statistics are there for us to be able to have cogent scientific things when we talk to clients. But you can be on the positive side of the statistics. If you shift in your mind to that place, you will keep going until you get it. So try the IUI, please. If you have, in fact, the UK guideline says that you should have 6 cycles. That's what the NICE guideline says. So there's the allowance for the fact that a seemingly healthy couple can actually do 6 cycles of IUI before they get pregnant from that IUI. So if you have to do it more than once, please keep going. If your doctor, if your gynae has offered you IUI, I believe sincerely you have a good shot at it. So please keep going on that. The second question, I can't seem to find it.
You answered it already when you're talking about the success rates. You're talking about the success rates.
So, okay, the person specifically, and I think this person is actually quite knowledgeable about what is going on in the fertility sector, because the person puts live births in quotes.
Yeah.
In quotes.
Okay. Medical person.
Yeah. So, so when we talk about success rate measured in live births, there are lots of there are other things that can come into play with live births. The quality of your antenatal care is one of them. Any coexisting medical illness is one of them. So most times, unless you are asking a particular fertility clinic, you may not get that broad general answer like that. You can have the success rate. That's a success rate in terms of positive pregnancy tests, clinical pregnancy from a fertility center. But for live birth, there are so many other things that can come into play like that. So success rates differ across the different fertility centers in Lagos. There's a success rate for positive biochemical pregnancy tests. There's a success rate based on clinical pregnancy. That is, have you seen the pregnancy on scan, seen the fetus, that's the baby, and seen the heart rate? That's diagnosing a clinical pregnancy. Live birth is when the woman eventually gives birth, and sometimes we don't have control over that. So I hope in a way I've been able to answer your question.
Thank you so much, Dr. Mojisa. Okay, so let me find the next. Okay, Dr. Akinola, I think you should take this. I've been trying to have kids for about 6 years. I've done different tests, scans, HSG, hormonal profile, and the only imbalanced hormone I have is high progesterone. I've done the different treatments recommended, yet I have not been able to get pregnant. What do you suggest? And then she says her husband's semen analysis is okay.
Yeah, but she tried assisted conception, because long duration of infertility itself is an indication for you to try assisted conception. Okay, is an indication to have assisted conception. So somebody who is waiting for 6 years for such a patient, again, I think is not really about finding cause or anything. It's about this woman, this couple needs assisted conception as long as it's still with the same partner. Now, the issue now is to determine which of the assisted conception is tailored towards her. You know, I didn't know, should she mention her age?
No, she didn't.
Okay, our age is also important, and also to look at AMH, anti-Müllerian hormone in the hormonal profile. That will guide us to look at what the ovarian this thing is if you're planning for ovarian stimulation. Okay, and of course, she said the husband's sperm is fine, right?
Yes.
Yeah, the husband's sperm is fine. So we need to, I think she should try assisted conception, and there are different options depending on a lot of things. Now, there are people who, right from the onset, they are not even good candidates to use their own eggs. They are not even good candidates to carry themselves. But at the first attempt, they won't agree because everybody wants to, I want to carry by myself, or hey, that's the one have that touch. Eventually, when they've gone around and cycle, they will actually find out that for different reasons, they have to get a surrogate to carry for them, or they may have to use a younger, a donor. Usually the donors are usually young people between the age of 21 and 25. And there are other things to consider actually before you say somebody is eligible as a donor. So what I just say in summary is that for her to have waited 6 years, I think she should know that. She didn't mention whether she had tried an IVF cycle. Okay, and that's an indication for her to try assisted conception.
Okay, thank you so much, Dr. Kenan.
Yeah.
And then I think we have the last question. Last question, let me see. I hope I didn't miss any question. Okay, there's one more before this one says, I think Dr. Mojisola, think that this is for you. Please, doctor, after the sperm has been released into the woman, that's during after ejaculation, it usually runs out, like it comes out, okay, comes out of the vagina. Please, what could be the cause of this, and can this lead to infertility? Dr. Mojisola, do you understand the question? Hello, do you understand the question, Dr. Mojisola? Something is wrong. Okay.
Hello?
Hello, can you hear me?
I think Dr. Muji cannot hear us.
Okay, I can hear you now.
Okay.
Okay, great. Okay. Did you get the question, Dr. Mojisola?
Yes, I did. The semen spills back out, right?
Yes, exactly. That's our question. So what could be the cause?
Okay,
exactly.
So it seems to be a kind of common question these days. Now I try to explain to the women, the vagina itself, it's a temporary container. The walls collapse during sex because there's something in there, that's the penis is in there, then it becomes, it has a space. Now, the volume of semen deposited is important. If the volume is high, yes, it's possible to have some backspill. If the volume is small, it's possible that there won't be so much of backspill. Okay, and when I explain to the women, I say, if you think that there's always spillback, after sex, put a pillow under your butt and lie down. All you need is just one sperm to be very active and win the Olympics and swim up through the uterus, through the tubes and all of that. You can ignore the 140 million other ones that are there. So it has to do with volume, one. And if liquefaction has occurred and there's a lot that spills back, it doesn't really mean that there's something wrong with that semen sample. If the couple is unsure, they can do an SFA. And then with that, they'll be able to tell if there's anything wrong with the semen sample. But with regard to spillback, it is not an indication that there's something wrong with the semen sample. And I've also come across a patient in my training. When they have sex, she will wash. She will go and douche and wash. And she said that was the instruction they gave her during, this marriage rites and all of that. So I now explained to her, I said, Madam, you have been washing out all the prayer point that you are going to church to pray about. That so next cycle, Don't do any washing. Just put a pillow under your butt and lie down. And then she came back to the clinic the next month after that with a positive pregnancy test. So cultural things can come into play with all of these things. There's nothing wrong with, that's the man's semen, unless you've done an SFA that says there's a problem. I believe I've
Thank you so
answered
much.
that question.
Yes,
You're
you have.
welcome.
Perfect. Thank you. Okay, and then the final question, Dr. Kela, does IVF increase the likelihood of a heart disease or other health issues? IVF or failed IVF? Let me add that to the question.
Wow. Well, that's it. I would like to know, let Dr. Aderomu, I want to know Dr. Aderomu's response first. Because
okay,
I can assume the reason why I'll be close. I'll tell you the reason why the patient has that question. Because maybe
Yes,
you of a popular figure that had
I know
IVF
exactly.
That's why I want Dr. Aderomu's response.
I added failed IVF. IVF and failed IVF.
Okay, so these days you have to sift. You have to sift. Even when we're scientists, we go on the internet and we're quoting studies. You have to sift when we talk about the strength of the evidence, the quality of the evidence, the level of rigor that evidence has gone through to say, is it replicable? Is it correct? Is it exact? So you can't just read one story and they just say, that's true. This is how it happens. The fact that one person came out of the house and fell into the gutter doesn't mean everybody that comes out of the house that day must fall into the gutter. IVF does not. People can have underlying conditions that were not apparent until they subjected their bodies to the rigor of IVF treatments, all the monitoring, all the hormones and all of that. And then if they do have, a condition afterwards, it doesn't mean it was that IVF.
Yeah.
It's just like if someone has a silent, we call it structural heart problem, it's been there, they are fine. But it's the day they went to play football and were running up and down for maybe 30 minutes, and then they collapse. You won't say it's the football, but it is the football by virtue of the work it has put on the heart that led to the unmasking of that silent problem that has always been there. So that's the only way I can explain that. IVF doesn't. And in addition, it doesn't cause cancer. I'm sure that's someone else.
That's another one. Thank you very much for
Thank you. And that's like, since you dodged that one, I have one more for you. What's the average cost of an IVF in Nigeria?
Of course.
Give us a range.
No,
in fact, that considering it.
So I think that also depends on different centers. It depends also on the type you are doing. Of course, if you are using your own eggs, it will be cheaper than you're using donor eggs. Now, another thing people should know is that even when you are using your own eggs, some people, you do 6-7 days straight of stimulation, you do your follicular tracking, the ovaries are already ready for egg pickup, okay, for the egg collection. You can't compare that to the patient that you have to stimulate for longer. And sometimes, if you do not even factor that into before the whole thing, you just find out that you're running at a loss. So it depends on a lot. Are you using your own eggs? Are you using your own sperm? Are you using surrogates? Are you using a surrogate, or you are the one carrying? Those are the things that would affect the cost, and it varies from one center to the other, and also, honestly, even though the cost in Nigeria, I must say, is still very, very low compared to outside the country. And a tragedy about it is that it's not supported by most health insurance. This people have to do privately. So it's difficult for you to say that this is the cost. I've had interaction with different fertility centers, so I won't want to mention that this particular place does this and all that. But it depends on a lot of things. Okay, those who are using donor eggs or donor sperm, of course, will be more expensive. than somebody who is using their own eggs and all that. And you can have IVF in 2 different places with different costs, because the agents used for stimulation may be different. The protocol being used is different. Some other people are adding cetrotide, maybe they give 3 days cetrotide. Some other people, maybe because that's what they are used to, they are using this, and for each of the HMGs, the cost of Gonalef is different from the cost of Menopur. Sorry, I'm not advertising any particular brand, but that's the reality,
Sure.
Just like you can have a particular medication, but they are different distance. So somebody using, even the HCG, maybe somebody is using recombinant HCG, Ovitrel, somebody is using the pure HCG. The thing will be different. How you do your egg collection also matters, okay? The kind of anesthesia, the kind of embryology support you have. Those are the things that will determine the overall cost before you say, oh, it's expensive in one place, one is expensive in one place. And these are the things one needs to really find out before arriving at the cost.
Sure. Thank you so much.
Excellent.
Someone is still asking. Maybe Dr. Mojisela can help us because she understands how women think. She's still asking. She says she wants a range. She wants to have an idea. Can you just give us a rough estimate, just a range? Okay. I will start from if I want to saving for this.
Okay, so because that's the field in which I practice, and I have an idea somehow about what clinics charge. Like Dr. Akiola has rightly said, it depends on the type of IVF that couple is going to do. So if that's even irrespective of which clinic it is. And he has pointed out all the things that go into arriving at a cost. You can get IVF less than 1 million at some clinics in Lagos. You can hardly get less than 500,000, but you can still get IVF for as high as 3-point-something million. So it depends on where you are. It depends on where you've gone to, the center you've gone to. Depends on the state in which you are. It depends on the quality of medications, quality of laboratory support that is available. Yeah. Because if you want to do TISA, and then the person doesn't have any facility to do it, you have to forgo that. If you don't have an ICSI machine, you can't expect. If you are doing conventional IVF, you're incubating with 100,000 rather than doing ICSI. Those things have a cost. Even the cost of cryopreservation, you have to buy liquid nitrogen. You have to pay for it. So those things come into the cost. So you can get for less than 1 million, depending on where you go, and you can get for way, way, way higher than 2 million, depending on where you go. But importantly is to ask, this is my medical history. What is the best for me? Because it's not like yam. Yam is not give me one yam. Even that one, you will see ask, is it Abuja yam? Is it cocoa yam? Is it back of the house yam? Is it, those are, you won't just say, give me any yam. So those kind of things are the questions you will ask to be able to understand why you are being asked to pay this or why you are being asked to pay that.
Thank you so much, Dr. Akela, I want to add something.
Yeah, I wanted to say that on the island, it's actually difficult for you to have it done with less than 1.5 million, even if you are using your own eggs. Actually, it's difficult to have it done. And forex issues are actually affecting the thing. There was a time in fact, it didn't really pay many people that had already collected money from patients, and they were now requesting for medications. It's not really a very funny moment for some of the centers actually on the island. So it's actually difficult to get it less than 1.5, to have it done less than 1.5 million.
How about IUI?
Well, of course, IUI is way cheaper.
Okay.
IUI is way cheaper.
Someone just asked IUI. Yeah. Okay.
IUI is
Thank you so
way cheaper. If you have a good gynecologist, you can actually, it's very affordable. Let me put it that way. IUI is easily affordable for the average Lagosian or Nigerian. Yeah. IVF, yes, can be out of the price range for a lot of people.
Thank you so much. So I know a lot of people want to reach out to you after this. So before we give our vote of thanks, I would appreciate if you could drop your email address or phone numbers or however people want to reach out to you. But Mojisola is not sure. You could drop an email address. Just something that people could maybe reach out to you, send a mail and ask for that question.
Yes, I can leave my email address.
So you can drop that in the chat room, please. Your email address or your phone number, if you don't mind, Dr. Akinola. So you could drop it in the chat room so people can reach out to you in case they have more questions or they have relatives that have questions. Just expect calls or mails. Thank you so much. I want to invite. I wanted to say Dr. Buki. I'm used to saying Doctor. Buki, are you still here? I want to invite you to come and give the vote of thanks. Thank you so much, everyone. Let's say a big thank you let us appreciate them in our own way in the chat room, please. A round of applause for them. High fives, thumbs up, smiles. You got this information for free. Thank you so much. I really appreciate you both. Thank you. God bless you too.
All right.
Buki, over to you, please.
All right. Thank you. Thank you so very much. Thank you, our doctors. We're grateful. Thank you for your time. It's been an insightful session, very informative, questions being answered honestly. And, I trust that everyone has been, they've taken a lot away from this meeting today. For the benefit for those who probably joined, I'd just like to tell us a bit more about the foundation. Of course, it's a social intervention vehicle, like I mentioned at the beginning of this webinar. And we run our initiatives, of course, through the education, health, and shelter. And one of the objectives for us in health is to offer periodic health program education, health promotion to target beneficiaries. And that is why we have one of these today. I'll just quickly like to appreciate our doctors once again. Thank you very much, Dr. Aderomu. Thank you, Dr. Akinola. We are so grateful for your time, spending your time, precious time and knowledge, just free, to everyone this afternoon. Thank you so very much. We know how much we have to pay if we need to come and consult, but you've given us so much this evening. We are so grateful. Thank you, ma'am. Thank you, sir. And to everyone, our moderators, thank you. Volunteers joining, thank you. All attendees, thank you for paying rapt attention, sending in your questions. I trust that it's been an informative session for you and you're able to take something away from this webinar today. We appreciate you all and we pray that every of your desires, everything that you want will be granted you in the name of Jesus. All right, thank you so much. We appreciate your time. We're grateful that this webinar is certainly a success. Thank you everyone for your contribution. Please continue to follow us on our media pages on Instagram, on Twitter, on Facebook, even YouTube, and also expect the recording of this webinar to also be posted live on any of our media platforms. Thank you so very much, and let us all stay safe. Thank you.
Thank you very much.
Bye. Thank you.
Thank you. Have a great weekend. Bye.
Thank you, everyone. Have a great weekend.
Bye.
Bye.